So like some of you out there, I'm an old oncologist, but that means I've been around long enough to see the transformation in the management of metastatic colon cancer. When I started a long time ago, 20 years ago, the only medicine we had was 5-FU. And over the last 1 to 2 decades, a bunch of new medicines have come into play. And our ability to incorporate these medicines into the management of this disease has nearly tripled the overall survival of patients with metastatic disease. And it becomes a sort of intricate, interesting chess game that we play with all of the medicines. Typically, we think of first-line therapy, fluoropyrimidine, 5-FU or capecitabine, Ox or Erie, everybody has their favorite, and then a biologic depending on RAS status, whether that's bevacizumab or one of the EGFR inhibitors. Then this concept of maintenance therapy after that induction chemo, where we can back off on the chemo and extend first-line therapy even further and minimize side effects. We then bring in second-line therapy. It was Ox to Erie, Erie to Ox, and sometimes change the biologic, sometimes maintain the biologic. But our strategy of intravenous chemotherapy combined with biologics has extended survival significantly. But the news, of course, is that we now have agents that take us beyond first and second line into third line. And of course, there are many others on the horizon, whether that's around immunotherapy or novel molecular targeted therapies. These things are continuing to come, taking colon cancer from a really terrible acute disease to much more of a chronic disease. So what we're going to focus on in this piece is really about the refractory setting and the new medicines that are there, how those chess pieces work, and how best to use them in your patients with refractory metastatic colon cancer. You know, so now we've known this patient a while, right? They have metastatic cancer, colon cancer. They've had frontline therapy, Ox-based therapy. They usually had Erie-based therapy, biologics at this point. There's, you know, now looking for what next. So a refractory patient with metastatic colon cancer. You know, we know this patient a lot. You know, you've talked to them 1,000 times, right? You know, their families, kids, all of that, right? We have a sense of their social support. So now we come to the next decision of, all right, we've got 2 agents in refractory setting. We have TAS-102, we have regorafenib. You know, how do you go about picking a patient who's the right one for what drug?
Sure. No, as you mentioned, after a while, patients become to part of your own family, and actually you become part of your own family, and you know them very well, and even you start to know like your life, your kids, your wife, all that stuff, and vice versa. And one of, I think, of the important benefit of that is that you can tell what's important for them, even without them saying that. And as a clinician, one thing you want to make sure, yes, your drug will work, or hopefully it work, but also you want to make sure the side effect fit their lifestyle profile, especially in that kind of stage. The refractories, they already received a lot of treatment, as you mentioned. So, for example, if I have somebody who's like to play guitar, I might choose not to give him Stivarga because of anything, but because of the hand-foot syndrome that affected his lifestyle. I had a patient who actually was going to play in a concert, and that was a determining factor. If somebody he kept having infection one after the other and low count, I might shy away from losing lung surf because of the count problem. So you have to tailor your therapy to what fit really for that patient. I think, in my opinion, colon cancer is a family name. I always think every individual person like is the son and daughter that shares the same family name, but it's different in own character.
Yeah. I know, Monica, you have a lot of experience with both these drugs and managing it, you know, from your side, from the nursing side. Are there issues that sort of distinguish where one patient you think might be better Lonsurf, one patient might be better Stivarga?
I think it's kind of like Dr. Salem said, a lot of times it comes down to side effects. But there's another thing too that sort of makes me think, the Lonsurf, the dosing is a little bit complicated.
Yes.
So we have some patients that really have trouble keeping track of oral agents. Sometimes it makes me a little nervous to think of them taking, you know, day 1 through 5, 8 through 12. Are they going to remember that? Whereas, you know, if they take regorafenib, 3 weeks on, 1 week off, it's like
Easier to remember.
Easier to remember.
So they're both, yeah, kind of complicated too. For me, I couldn't agree more. So I've got a patient with hand-foot syndrome already because I use a lot of capecitabine, as you guys know. I mean, that's maybe going to go over to TAS 102, whereas if I got somebody with significant myelosuppression. One of the things I like to make sure of is to not wait too long, though. You know, because we have access to phase 1 trials and other kinds of treatments for patients. So, you know, we try and don't wait too long is one of the key elements I like to give in patient selection.
Yeah, I agree. And I also always say to my patient, you don't have to have that drug or this drug. As long as you have an option, that is the key to extend life and do well.
Yeah, great.
We have patients that are wondering a whole host of questions, especially a lot of these patients have not been on oral therapies before, so they're asking me, is it okay for me to be taking this medication at home? They want to know what foods they're able to eat. Are they able to take stool softeners along with it? Does pain medication interact with the medications that I'm on right now? What kind of foods do I need to eat? Because some medications have certain, you can only eat low-fat, you know, diets or around the time that you're taking the medication.
So a lot of times, you know, we tell patients about both of these medicines, you know, or they've gone online or some support group thing has told them, so they know about both of them. And we do our best to try and inform them of the risks and benefits and sometimes let them decide, right? I mean, they come down and have a preference for one or the other. I know you've had that experience. I know we've had that experience. And so I do think that's a reasonable strategy for some patients is to give, in the right patient, give them enough information so that they can have a choice in this as well.